This is In Your Right Mind with Dr. Tonmoy Sharma. I'm Bree Chilton, and we're here with Dr. Cervantes.
So, we talked about stigma and its impact, and you said something that was, I think, should be part of the normal vocabulary of psychiatrists, a brain attack. And the brain is affected by a variety of things. But in depressions, you've got changes in the neurochemicals that affect mood, so to speak. Well, can you talk about that a little bit?
Yes. So for a very long time, it was believed that a decrease in serotonin was the primary or the reason why people became depressed.
Oh, yeah. I remember this study from, I think it was University College London and maybe Cambridge, I'm not sure, that really blasted that myth of serotonin, which has been there for 30 years now?
Yes, exactly.
All antidepressants were based, almost all antidepressant drug development was based on that premise. And somehow it's all different. It's an astounding finding.
Yes. And so since that article came out, it did cause a lot of controversy, and some people on one side of the spectrum were saying, well, then what's the point of serotonin reuptake inhibitors? It's a farce. We should stop all antidepressants that have to do with serotonin. In the middle, you had people saying, no, wait, hold on a minute. Mm-hmm. Clearly, they do work. They do help. Some people have had improvements in their depression. Yes. And then more recently, some people have come out and actually made some very important clarifications, saying it's not necessarily because they increase serotonin in the synapse. And for the layperson out there, basically, the way that these antidepressants work is that you have two communicating brain cells, and in between you have a space. And the brain cells communicate both electronically and chemically. So you have a little zap that goes across a brain cell, and interestingly enough, that electricity converts into a chemical reaction, meaning that you have these little, let's call them bubbles of neurotransmitters is what they're called, and they're released into that gap or space. And then they travel across to the next brain cell, and then that stimulates, when they connect, another electrical response. It's fascinating.
So we have these neurotransmitters. They're really, people have heard of dopamine, serotonin we talked about. So these are chemicals, right? So
correct.
That are produced in the body. And then there is another group that has an effect, which are hormones.
Right.
So in terms of neurotransmitters, that recent finding obviously caused a lot of consternation in the community, or at least in the psychiatric community, in terms of what are we going to do. But what are the other neurotransmitters, if at all, that are affected?
So other antidepressants can affect dopamine as well as norepinephrine. But what I wanted to say really briefly is that what has been said since that article came out is that it's not necessarily the serotonin that's being increased in that space between the neurons that's improving depression, but rather it is that there are changes inside of the neurons that occur over a period of time with these medications, which it makes sense because it can take 3 to 6 weeks for you to feel a response to these antidepressants. So clearly the immediate reaction of more serotonin gushing into that space isn't what's improving depression. It's something else that takes time and has probably nothing to do with serotonin or some kind of a lateral effect of that serotonin increase. But I just wanted to make sure that I said that because I on the one hand I do believe that serotonin reuptake inhibitors have been put on a pedestal or made like the primary treatment for depression, which has done a big disservice to some people who have needed other treatments.
Right.
And so we can go into those later. But as far as what other antidepressants treat, there's dopamine and there's norepinephrine. And in fact, more recently, we're getting medications that are treating glutamate.
Right. So norepinephrine, people would also know that as adrenaline?
So norepinephrine is a precursor to epinephrine, and epinephrine is what we, kind of identify with adrenaline.
Okay. So it looks like there is a change in the neurotransmitters and probably what is known as like a stereotactic or a configuration change, if you like. Mm-hmm. And does that happen in the receptor or does that happen in the neuron? What do people say?
There are changes in the receptor, but the belief is that there are actually changes going on inside of the brain cell that have to do with some of these transporters and, very complicated things that are going on inside the brain cell.
Well, hopefully one day we can talk about neurogenesis and talk about how we can grow brain cells. But that's on a future date.
Yes,
so apart from that, are there any other changes that you can think of? If not, it's okay.
You mean with
depression? Are there any? We talked about the physical changes,
yes.
right? Mainly loss of weight, but with people like us, it's more about gaining weight when you're depressed and comfort foods and the rest of it.
Well, actually, one that I haven't mentioned yet is that people start to have a difficulty focusing and concentrating.
Right.
So not only is attention impaired, where people will get distracted, when your attention is not quite what it was before, and you might miss something. You might start to forget your keys because you're distracted. But also your ability to focus on a task and get things done at work. And unfortunately, if you're already experiencing sadness and you're already feeling all of these other things, and you're feeling some cognitive impairment as a result of this difficulty concentrating, now you might actually start to feel down on yourself, like, what's wrong with me? And then you have negative self-talk, where, and it becomes a vicious cycle.
Right. And I guess trying to think back on my days when I was teaching, so it's psychomotor retardation is the clinical term.
That's right, yes.
So you're slow, both in terms of your movements and your brain processing. That brings me to a sort of favorite topic of mine, which is cognition. So we have cognitive impairment in depression as well.
Yes,
okay.
Absolutely.
And you mentioned attention. Are there any other domains that are affected?
Cognitively?
Cognitively.
Processing speed. So, it's not just like, can you focus, but how fast you can think things through. And with the psychomotor retardation is like people will take a long time to answer a question.
Right.
And actually the ultimate, I remember seeing one patient way back when I was a resident who had, her depression was so severe, she was catatonic. And what catatonia is when somebody basically doesn't move. For all intents and purposes, they are paralyzed. And so, they can move. Their spine is great. Everything, they have strength, but they, it's almost like they just, that's
almost
motor,
like a vegetative
slow
state.
Yes.
But the brain is functioning, unlike being in a coma or being completely out or having spinal injury. So is that, I know we'll talk about treatment in a moment, but it seems like people with catatonia, and you can get catatonia with psychosis as well, right?
Correct.
So these seem to be prime candidates for ECT. I know people have got their own views about electroconvulsive therapy.
Yes.
But
Yeah.
do you think it's appropriate?
Absolutely. I mean, if you're in a condition that is so severe that you cannot move and, nothing else works, then that would be a definite, treatment to try.
Right.
Yeah.
So we talked about catatonia. So does cognitive function get restored? Or is this a permanent effect, or does it get restored as your mood improves?
So it does get restored. As your mood improves,
Right.
things start to come back online. One thing I was going to say about ECT is, with electroconvulsive therapy, there is also a stigma in and of itself.
Yes.
Of, oh my God, they're going to shock you. And, people have
One
these
flew
images.
over the cuckoo's nest.
Right, or worse, they think of Frankenstein and electricity. So it's actually a very it flows very smoothly. You're in a hospital gurney. They attach a blood pressure cuff to your calf. You have an anesthesiologist provide sedation, and then you have a stimulus of, electricity that technically could cause,
It's
a
like
seizure.
jump-starting your brain, right?
Exactly, it's like rebooting your computer.
Right.
Which is, if a lot of
Like
people don't think twice
let's-
about rebooting their computer,
Yeah.
but
So-
why not reboot your brain?
Right. So we are
and-
learning new things today, like rebooting the.
I didn't know that was an option.
Yes.
Rebooting the brain.
Get it back
talking
online.
about sort of brain attacks.
I need that on
I
Monday
think
morning.
this should become part of the
Every morning.
normal literature. So every morning, yes. And then you're done. Well,
and
maybe
it's-
coffee does that to us
That's
a lot.
true.
And I think if
That's why Starbucks is so successful.
right, and if people were
Now
able to,
we have to get a sponsorship. Now that I
I
said
know.
yeah.
Make sure you put it in the view of the camera.
But and one last thing to be said about ECT or electroconvulsive therapy is that one session wouldn't necessarily be enough. You'd have to have a few of those, and obviously you have to, go into the hospital to get it done. But it's an outpatient treatment, so
Right.
I wanted to make sure
Yeah. We have to take a break now, and
Sorry.
when we come back, that's
get
okay.
carried away.
That's okay. Well, we need you to get carried away because then you're finding it interesting. When we come back, we'll talk about treatments. We've touched on ECT, but there are a variety of pharmacological and non-pharmacological treatments.
sounds good.
This is In Your Right Mind with Dr. Tonmoy Sharma. I'm Bree Chilton, and we're here with Dr. Cervantes.